Welcome to the second annual Joint Visiting Professorship in Cancer and Aging Grand Rounds. I'm Tom Gill. I direct the Yale Program on Aging. The overall objective of the Cancer and Aging Visiting Professor Program is to strengthen collaborative ties between the Program on Aging and Pepper Center and the Cancer Center and Medical Oncology. Roy Herbst and I believe that there are a lot of untapped collaborative opportunities at the interface of cancer and aging across the continuum of research, from the most basic, translational, patient-oriented, and health services. The visiting professor meets with faculty and trainees from our two programs individually and in small groups, and advises us on potential collaborative opportunities. The inaugural joint visiting professor last year was Harvey Cohen, and I'm going to turn the podium over to Roy so he can introduce our second visiting professor.
So thank you all for coming, and Tom, it's been wonderful working with you and having these joint grand rounds and other meetings during the year. So for the second annual Oncology Geriatrics Grand Rounds, we're really very fortunate to have Arti Hurria with us. She's a medical oncologist, director of the Cancer and Aging Research Program at the City of Hope. She's also co-leader of the City of Hope Cancer Control and Population Sciences Program, and I learned from her yesterday the Vice Provost of Clinical Faculty and a professor in the Department of Medical Oncology and Therapeutics Research. So Arti specializes in the treatment of cancer patients aged 65 years and older. I've become more interested in this as the years have gone on for myself as well. Actually, if you look at the data, this really comprises, such a large number of the patients we care for with cancer, and as you'll hear today, there are special issues. It's over half the breast cancer patients, for example, in the United States. Very well trained as a geriatrician and an oncologist, both boards. She had fellowships at Hartford and Memorial Sloan Kettering Cancer Center, and really looking at improving therapy and chemotherapy for older patients. Multiple honors. Her CV is quite thick. I'll just give you a few. The Frederick Sten Memorial Award for Humanism in Medicine, and the B.J. Kennedy Award and Lecture for Scientific Excellence in Geriatric Oncology. And she's a director of the ASCO board. So we're really honored to have you here today. So Arti, if you'll please come up. We always like to give our special guests something from the Yale Cancer Center Smile Cancer Hospital. So you'll have our vintage fleece, which hopefully nice. On those cold days in California there, you can wear those.
Beautiful.
And thank you.
This is great.
And it's really wonderful to have you here today.
Oh my gosh, thank you. I love this. Well, this is great. And I will wear this with much pride. I'll wear it with much pride because so many of you in this audience have been great friends, great colleagues throughout the year, and to be here and to have a chance to bring these two fields together, both of which have been so dear to my heart, is a really a true honor. So with that, I thank you for the opportunity to be here, for us to be able to be together, and I'm going to talk about cancer in older adults and the top things that I feel oncologists need to know, but really it's healthcare providers in general. So we'll talk about what are the demographics right now of cancer and aging, what are the workforce and the educational needs, aging and the implications for cancer treatment. So what do we have to think about when we're giving cancer therapy to an older adult? How do you identify which older adult will be able to tolerate treatment, who might have a harder time with the therapy, and do we need to think about modifying the way we're approaching those patients? And then lastly, how can we make this a little easier for our healthcare team? Is there a way we can use technology to help to perhaps maybe decrease the burden and improve the quality of care? So with that, Dr. Hertz had just told you that cancer is clearly a disease associated with aging. So really, we talk about geriatric oncology, and I'm going to argue that there is a very specific skill set there, but the truth of the matter is, these are our patients. 60% of all cancers occur within patients who are age 65 and older. So these, if we represent the patients that we see in everyday practice. And when we think of deaths from cancer, it's about 70% of all deaths occur in people who are over the age of 65. So overall, cancer is clearly a disease associated with aging. Age is the #1 risk factor for cancer, barring all other risk factors. And these are the patients that we care for. And what's happening right now within the U.S. is very interesting from a population perspective. So in 2011, the baby boomers started to turn age 65 and over. And what's happening is that we are seeing the largest growth right now is in the 65 and 70 plus population because of that. But what's going to happen is that 2030, and 2030 isn't so far away, our largest shift, the largest growth is going to be in those age 80 plus. This is a group who we have almost no evidence-based guidelines about how to treat patients who are age 80 plus, yet it's coming and it's on its way. And what we know is, what is this going to mean for us as oncology care providers or individuals who help care for this population, is that there is going to be a rapid increase in cancer incidence. And we're seeing this. We're feeling this stress in our healthcare system right now. We're in the midst of it. So what we know is that from 2010 to 2030, there is going to be a 67% increase in cancer incidence in patients age 65 plus. So these patients are driving the increase in the number of cancer cases that we're going to see. In comparison, only 11% in patients who are less than age 65. So what we can say is that the good news is we're curing more patients. People are living longer and longer. And another major issue that's really facing our field in a very good way is that most survivors are older adults. So here are the younger cancer survivors, less than age 60. These are the older cancer survivors. A huge opportunity for research about what are the chronic implications of therapy, how does that interact with the aging process, and are we creating in some way an accelerated aging phenotype among older patients who have received cancer therapy. So take-home message number 1, I'm going to give you 5 take-home messages to remember from this lecture. Number 1, cancer is clearly a disease associated with aging. The U.S. population is rapidly aging right now. The majority of both cancer diagnoses and cancer deaths occur in older adults. The number of older adults with cancer is on the rise. And the question really is, what are the implications for you, for me, for those who are in leadership positions in this field? What are going to be the implications for our oncology workforce? And how are we going to really deal with this shift in demographics that's occurring? And honestly, the statistics are a little bit worrisome in this regard. So this is the American Society of Clinical Oncology Workforce Study, looking at what is the future supply and demand for oncologists. So I see a number of young folks out here in this audience. If you go into either oncology or geriatrics, you're all set in terms of job security. This is definitely a field that you should pursue. But here you can see this is supply, this is demand. And here's where we are in 2020, just 3 years away. So if you are feeling the stress of needing to see more patients in a shorter period of time, making the system work even more in a more well-oiled way than before, the truth of the matter is that that's right. If you're feeling that there's a graying of your waiting rooms, that's absolutely correct. It's not something you're just feeling. This is what is truly happening. So you might say, as an oncology care provider, that's fine. I'm going to deal with the cancer. Let my geriatrician colleagues deal with the geriatrics part of it. And it's a reasonable, I think that's a reasonable thing to think. And now here you actually have geriatricians, but let's talk about really what the reality is in geriatrics right now, and is that a plausible solution? So here we have our happy doctor in the middle, and we have the number of patients age 75 plus to geriatrician ratio. My daughter helped me make this slide because she really likes happy faces. But the bottom line is that very happy doctor all of a sudden is becoming unhappy because the present truth of the matter is there is one geriatrician to 2,620 patients out there who are age 75 plus, which is a pretty high bar, right? I was talking about 65 plus. Where are we going to be? 2030, there's going to be one geriatrician to 3,798 patients. So if you know a geriatrician or one is by your side, hug your geriatrician colleagues, because they're a really rare group of people out there, and we need them in order to help think about how are we really going to care for this growing patient population. And the answer won't be let's refer to geriatrics, because there just aren't enough of them. And this is where we are in terms of the number of geriatricians that we are thinking are going to be out there for this group of people. So even though I've just told you cancer is a disease associated with aging, in fact, most diseases are diseases associated with aging, and that we're going to have a rise in this patient population, and we are going to be caring for more of these individuals, there's actually an anticipated decline in the number of geriatricians within the U.S. It's probably a social statement that we need to think about together at some point, maybe over a glass of wine, but it's a problem. And so, again, it's a group that's becoming rarer and rarer, and where their skill set is becoming even more valuable. So what happens is it's forcing us, all of this, to think about newer models of care. And I had the honor of sitting on the IOM Quality Cancer Care Committee a few years ago, and a major focus of that was actually about geriatrics, because the question is, how are we going to do this? Rising population. Right now we think about, okay, there's a patient, the doctor, sometimes the extenders, physician assistant, a nurse who works with us. That's our general care model, right? But what the truth of the matter is that based upon this growth in the population, we're going to need to use the principles of geriatrics, where we embrace a multidisciplinary team to take some of that care off of the oncologist's plate and to work together with rehab, pharmacy, social work, or even more importantly, and this is a group where we probably are not spending enough time, are the family caregivers and home health care aides. Because the truth of the matter is, we look at admission times, we're trying to get people out sooner and sooner. They need the skills to be able to care for this group of patients. And that's a group where I think we need to be putting some of our energy. But the truth matters, these are the principles of multidisciplinary care. This is geriatric medicine. We work together as a team to care for our most vulnerable patients. So the challenge is that there's a need for education and training, right? This is a whole skill set. And the Institute of Medicine Workforce Report said the healthcare workforce receives very little geriatrics training and is not prepared to deliver the best possible care to older patients. Well, is that really true? Well, I guess if we look at the numbers, I think the answer is yes. So here you can look at each profession and the percent of individuals that have training within geriatric medicine. For doctors, it's 1% to 2%, but even more concerning are the people who are right there at the bedside often. Nurses, less than 1%, physician assistants, less than 1%, pharmacists, less than 1%, and social workers, about 4%. So it's not just doctors, it's not just nurses, it's our whole field that we're going to need to provide educational opportunities for. So you might say, well, what are those opportunities that are out there? So I want to highlight just a few, because I think some of these are low-hanging fruit, and I hope that you'll take advantage of some of these opportunities. First, because of this challenge of education and the real lack of it within and integration between geriatrics and oncology, we had something called a U13 grant that was a grant that was in collaboration with the NIA and the NCI and the Cancer and Aging Research Group. And our mission was to say, okay, here's where we are right now. This is the present level of evidence. And we want to identify what are the highest areas of research priority in this field. And then we want to give you a roadmap on how to get there. Talk about the research approaches to improve clinical care, that being the ultimate goal of patients with cancer. And there were 3 conferences that were held in succession, all with really the top experts in the area that told us, how do we build these studies? So first, if you're going to build a study for an older patient with cancer, what are the biological, clinical, and psychological correlates that you should include? Number 2, how do we design and implement these studies? And then number 3, with number 2 being specifically therapeutic studies, and number 3 being, what about interventions to improve quality of care? And it led to this roadmap, 3 major white papers, which I hope are relatively easy to read, but also 15 other papers that many junior individuals in our field had led, Carolyn Presley being one of them, to really get down to the nitty-gritty of whatever type of study it was that you wanted to be involved in. And on our Cancer and Aging Research Group website, we actually have something called the U13 tab. So if you were designing a study in GI malignancies, for example, there's a whole lecture by experts on what are the unique issues facing older adults with GI cancers, and what do we think the study design should be, and where are the high ticket items to really focus on. So all those lectures are up there with the slide sets, and we hope that this can be something you can utilize. The second is, I know many of you may be outside of the field of oncology, maybe you're another subspecialist, but this is for oncologists, and this is something that's a very important grant mechanism because the pay line's pretty good, and it's a real opportunity. So here, the NIA got together with the AGS and the Hartford Foundation, and we put together a conference series to support what we call the GEMSTAR awardees. These are physician scientists within subspecialties linked to geriatrics who are doing something within the field of aging. And they do a research project. It's an U13 grant with a career development component, relatively good pay line, as I said, and they have the opportunity to then be a part of 3 interdisciplinary meetings, 2 of which have happened, 1 on frailty, 1 on biology of aging, and 1 on cognitive function. And if you were a nurse in the audience, we have this opportunity for education. There's an R25 grant. We will pay for you to come to sunny California. It's a nice deal. We try to take really good care of you. But the whole goal of this grant is it's a geriatric oncology curriculum for nurses. So here we are educating 400 nurses over 5 years. What we know is that oncology nurse care providers get very little training in geriatrics. This provides an opportunity for them to come to have a 3-day curriculum. The nurses come in teams of 3. So there's a manager, and then an educator, and then a direct care nurse. And it's train the trainer. We train you, and then we ask you to implement a project of your liking within your cancer center. And again, we help support your trip to us. And then we do follow-up with you. We have monthly conference calls with all the participants. They present their research to us and their project. They tell us about their barriers, and we try to help them overcome it. So the IOM says that we need a substantial focus. We need a substantial focus in our healthcare infrastructure to provide skilled care to this vulnerable population. The question really for all of us is who's going to set the bar for that? We all have aging parents. We all have, grandparents. Who's going to tell us as a healthcare industry what type of training we need to care for this vulnerable population? So because I'm from California, I'm allowed to poke fun at California. So this is the number of training hours required in California for a direct care worker of an older adult. You need 150 hours to be able to care for my vulnerable older adult, and you are licensed to be able to do so. Now, my manicurist needs 350 hours in order to be able to do my nails. My skin care specialist needs 600 hours in order to do a facial, and my hairstylist needs 1,500 hours to be able to be licensed to cut my hair. Now, you might say, I value those other things. I don't disagree. However, we need to change the bar. This is so clear, right? And this is the thing. This is you and me. This is, we can say who's going to change the bar. We're the ones who know who vulnerable they are. We're the ones who take care of them in daily practice. We're the ones who have to discharge them to that home care individual and make our healthcare systems work, right? So that we know that our patient will not get readmitted, that they will get good care. So if there's a part of you that's involved in policy and advocacy, I couldn't say that I had that, thought in my mind when I first began my medical education, but it's changed. It's made me realize that we can change this bar and we can do it together because we can speak for our patients. So take-home message number 2 is there is a major workforce shortage. To meet the healthcare needs of the next generation of older adults, the IOM says the geriatric competence of the entire workforce needs to be enhanced. Innovative models need to be developed and implemented. So this is a huge opportunity for us. Many of us are at an incredibly exciting time in healthcare where we are sitting at the table to develop these models of care. We are shaping what's happening in our own cancer centers. The question is, how can understanding the aging process help with facilitating this quality cancer care? We keep hearing about quality value. How do we understand aging, and how can that help us care for older adults with cancer? So this is my favorite doctor, Dr. Seuss. Dr. Seuss says you're only old once. Aging begins from the minute we are born. And I show you Dr. Seuss in this quote because I think sometimes we think of geriatrics and we think of them. That's them. That's not me. No matter what age you are, you feel young, and you don't feel geriatric. I can tell you that. Dealing with a lot of people who are older adults, don't call them geriatric because they don't feel that way. So the challenge is that aging begins, though, from the moment that you're born. So all of us are on an aging trajectory. In fact, we're on this aging spectrum. And when I think of pediatrics, I think of this population that really requires a unique skill set. They have age-related changes in physiology, they're vulnerable to toxicity, they're dependent in their daily activities, and there's concern about the long-term effects of therapy. So much so that when my kid has an ear infection, I'm not going to prescribe the antibiotics because I'll screw it up. I want someone who really knows what they're doing to take care of that individual. Now, if you look at the other end of the spectrum, you can imagine that it's exactly the same, right? This is a group that has age-related changes in physiology. They are vulnerable to toxicity. They can become dependent in their daily activities, especially if we cause that toxicity, and there's concerns about what happens, what's the long-term implications of what we do. Hence, I just show you this to say that there is an opportunity for us to work together to really merge these two fields and to try to think about what are the unique skill sets that are needed. Let me make it a little clearer even. Here's pediatrics, right? You go to the pediatrician. Your child's 6 months old, and you're looking at this graph, and you're thrilled when the pediatrician says, oh, they met the milestone. They're doing fine for 6 months. We all clap our hands, everyone's happy, the parents go home, things are good. Chronological age equals functional age. It's relatively straightforward. If you follow the map, you're doing okay. What happens when we age, right? You can take two people here, chronological age 80. The map doesn't exist anymore, right? There is no chronological age equals functional age. The two have dissociated, usually entirely. And you're trying to figure out where are they on the spectrum of this. Now, one of these women is flexible. By the way, do not try this at home. When I first saw this, that can't be that hard. That can really hurt. So, this is really hard to do. But you can be, very flexible, independent, or you can be wheelchair bound. And your treatments for each of these patients, no matter what their chronological age is, and no matter what subspecialty you are in, will be completely different. So the challenge is that it's often not that obvious. So I show you these two pictures, and you're like, I got it. One's a chronologic 90, one's a chronologic 60, but what we know if we see patients, we know that when the patient's sitting there in a gown, it's hard to figure out what exactly their functional age is. You've got to do a little bit more work. And the other challenge is that it's often silent. So the aging process can be silent, but it's going to happen at every single organ system. So this is nerve conduction velocity, basal metabolic rate, heart output, kidney blood flow, or maximum breathing capacity. So here's the humbling news. These age-related declines start at age 30. So anyone who doesn't feel like you're aging, we're all on this aging trajectory, right? But you can modify the slope of this. So it is different for different individuals. It's happening, though, to all of us. And as I said, sometimes the biggest challenge is that these declines that occur with aging can be silent. So we get a serum creatinine when we're seeing a patient, and we want to dose chemotherapy. And if they're 40 and their creatinine is normal at 1.4, their creatinine clearance is 79. But if they're 100 and their creatinine is 1.4, their creatinine clearance is severely reduced to 32. Hence, some normal things that we have in our daily practice are not that informative as we're caring for an older adult. We have to dig a little bit deeper. Now, the other challenge is that you might not see this decline in organ function until you stress someone. And chemotherapy is the perfect stressor. So you take someone, they look fine, right? And you try to figure out how much can I push them before you're going to end up tipping and causing a challenge. So here's an example. Let me just give you an example of another organ system. Here is heart rate. And here is maximum heart rate. You're age 20. You see the patient in the emergency room, right? The patient has a heart rate of 190. You get out, the SWAT team, everyone's going to go because you're like, something's really bad, something's happening, it's not good. You do the same thing to someone who's 80. Their maximum heart rate will be 140 or 150. They cannot mount that same response to that stressor compared to a younger patient. Hence, a heart rate of 140 or 150 in in an older patient who's in the ER is a reason to have the SWAT team come out. And you can figure this out. This is maximum heart rate. So bottom line is that in response to a stressor, they're not going to be able to mount the same response. So the hallmark of aging is that you have decreased physiologic reserve. We all start with a full tank of gas. The gas starts to go down with each decade. There's a point where we are trying to figure out what the reserve is. And the question is, how do we calculate that? When are we going to go to empty is really what the question is. So physiologic reserve, the easy way of thinking of it, this is our fuel that's available. Now, before I go on to tell you how do you figure it out, this is the thing. You can build that reserve at any age. So if you take care of older adults of any age, the key is that it does not, even if you are 80, you can build reserve. If you don't believe me, look at this top senior gymnast, Johanna Quast, who went back to being a gymnast in her 70s. This guy is real. He became like the mascot for our team. He just died last year, so it was very, very sad. But Banana Blair George, 92 here, water skiing without skis. Some people have said that this is a sign of cognitive impairment. I should not use this slide. I got to really rethink the whole talk, they've said. But, clearly muscle mass, very physiologically fit. And then here's Fauja Singh, a 100-year-old who ran a marathon. And his story was that he had lost his wife and his child in his late 80s and could not recover from that emotional stressor until he started running. And he took it to an extreme, of course, and decided to marathon run, but it's just an example. So there's hope for all of us and I think about this every time I go to the gym. There is hope. I could be like one of them. So take-home message number 3, chronological age does not equal functional age. Aging is very heterogeneous. The aging trajectory is modifiable. A hallmark of aging, though, is that there is going to be a decline in functional reserve and organ reserve. We need to be mindful of that. It's probably not going to be obvious at rest. You're not going to be able to figure it out looking at the patient, but it will be obvious when you give them a dose of the stuff that we give, chemotherapy or immunotherapy as we're figuring it out. And chemotherapy is the perfect physiological stressor that can unmask the decline in physiologic reserve. And from an aging perspective, actually patients with cancer might really help us understand aging because it might tell us what are those risk factors for decreased reserve. Now, I've just told you there's a whole need for data in this area. We treat these older patients. The challenge is that most of our cancer studies have included a younger patient population. So this is looking at the data from the FDA, 7-year period of time. And what you can see here is if you look at patients over the age of 65, over 70, over 75, this is the percent of patients with cancer. This is the percent enrolled on the trial. Almost no patients over 75. This is a gold mine for a cancer center that wants to do research that no one else is doing because this is an aging population and there is almost no evidence-based literature about how to best treat these patients. This is updated data from ASCO. The FDA gave us their most recent report, 10 years of data now, 224,000 patients. Again, this is the proportion of patients within each age strata who have the disease, and this is the proportion on FDA trials. What you can see here is that the greatest disparity is going to be in patients who are over the age of 75. This represents almost 30% of patients with cancer. 1 in 3 people who you are going to see is going to be within this age group, and there's almost nothing in the labeling about how to deliver those drugs to this patient population. So again, a huge opportunity in terms of therapeutic research. Now, you'd hope that maybe we'd see some other statistics that look better, but the truth of the matter is no, this is data from the Alliance. Actually, more than that, all NCI cooperative group studies, we put everyone together. This is in green, patients less than 65, 65 to 74 and over 75. Over a decade, no real change. So again, another real, I'd say low-hanging fruit, opportunity to change cancer care within a very small period of time. But where are we right now in terms of what we know? What we know is that most of the literature that's out there is saying, yes, older adults are at risk for side effects. That's the state, in some ways, of what we know. And the truth of the matter is, it's not really a surprise, right? We haven't studied this group of patients. So how do we dose the drug? How do we deliver it? What are the side effects we need to anticipate? The doctors are outstanding doctors. The challenge is they've not been given the information that they need. But the question is that, are we going about this the right way? So I sort of think of medicine, you take the patient, they look totally fine, you give them a dose of treatment. And then they get the side effect, and they come into the emergency room with the fire. And we bring in the whole squad to come put out the fire. Everyone's consulted. Cost of care is huge, and we react. We react very well. But if we were not medicine, if we were any other business, would we ever allow the fire to occur? Do you think the people on Wall Street are waiting for the fire to occur? They're anticipating who is going to have the fire and how do we get ahead of it. And so that's really what we've tried to do over the last decade and a half of research, is say, can we anticipate the side effects? And can we utilize the skills of geriatrics to identify which older adults are at risk for side effects from cancer therapy? And so a geriatrician, when you send a patient to a geriatrician, they do something called a geriatric assessment. And what they're doing is they're looking at the patient in terms of items other than chronological age. They're saying, okay, what is that individual's function, their other medical conditions, nutritional status, cognition, psychological state, and social support, and are there other medicines that we will prescribe that might interact with the medicines that the patient's taking? This has this complicated name called a geriatric assessment, but this is essentially what a geriatric assessment is. It's looking at the whole person. Each of these individual domains predicts the risk of morbidity and mortality in older adults. But the challenge is that how do you bring those skills into a whole other subspecialty? And I had the honor of meeting with some of the fellows and junior faculty this morning, and I told about my story. I was in a geriatrics fellowship, and we were seeing a bunch of very, very complex individuals. We had a significant amount of time per individual, and we provided outstanding care. And then I went to, probably one of the world's best comprehensive cancer centers, and we saw 30 to 40 patients in a day that were way more complex, and we were going to give them chemotherapy. And I came in as a geriatrics fellow, and I said, we can't do this. We have to assess these people. We have to figure out what the issues are. And I realized very quickly that was not going to work, not in the pace of oncology care that our oncologists are being pushed to be able to operate at because of the volume of patients. So we started and said, well, let's develop a geriatric assessment for oncologists. Let's try to make it a little bit easier. And here took a multidisciplinary team and a lot of people who were super smart, way smarter than me, about measures and what are reliable and what are valid, and can you use some, self-administer some of these. And we developed this assessment. And as we developed the assessment, there were only 3 things that a healthcare provider needed to do, and this does not need to be a doctor. 1 was rate their Karnofsky performance status, because we do that as oncologists. Number 2, a timed up and go. It's a performance-based measure of functional status. So what you do is you have a patient sit in a chair, they get up, walk 10 feet, turn around, walk back, and sit back down again. And you time how long that takes, and that amount of time, if it's more than 13 seconds, risk of falls is significantly increased. And then lastly, there's a measure of cognitive function, which is relatively brief, the Blessed Orientation, Memory, and Concentration Test. But developing the assessment was not really, we needed to do it, but what we really wanted to know was this question of, can you predict chemotherapy toxicity? So if you do this assessment, can you identify who is at risk? So here's a study where we took patients aged 65 and over, diagnosis of cancer, to start a new chemotherapy regimen. The doctor was the doctor. They prescribed as they thought was appropriate. We did not interfere in any way. We just captured it all. And then we did this pre-chemotherapy geriatric assessment. We graded their toxicities at each visit. And here we were looking for NCI grade 3 through 5 toxicities. So we're looking for the big ones, not necessarily an ER visit. We're looking for grade 3, were you hospitalized, grade 4 ICU admission, grade 5 treatment-related death. And then we completed the assessment again. We did this across 10 sites, Yale being one of them, and I'd like to acknowledge Dr. Carrie Gross, who's been along this ride for a decade with us. We did 500 in a development cohort. I'll show you the results, and then what we said was, we're not sure, we want to make sure it's right. Let's do another validation cohort, and we did that. And this is what we found. We found that there are several predictors of chemotherapy toxicity, but you can really decrease it to asking 11 simple questions to get a sense of where is your patient on the spectrum. Where is your patient on that physiologic reserve risk? Number one age was a factor, age greater than 72. And that's because usually in that 7th decade of life, we do start to see the physiologic declines of aging, but it's one of 11 factors. The other factors were, do you have a GI or GU malignancy? So all solid tumors were included. Those patients are particularly at risk. Are you getting a standard dose as per our NCCN guidelines? Are you getting polychemotherapy, more than one drug? Are you anemic, or do you have poor renal function? And then there are 5 geriatric assessment questions that predict the risk. Number 1, have you fallen in the last 6 months? Number 2, do you have hearing impairment that you would rate as being fair or worse than fair? 3, are you limited in walking 1 block? 4, do you need assistance in taking your daily medicines? And lastly, have you decreased your social activities because of either your physical or your emotional health? You can see here heavily function-based, falling, limited in walking 1 block, decreasing social activities. Hearing impairment, many people have asked me, what do we think about that? Hearing impairment might be a global sign of physiologic decline. It might be as simple as, did they hear us? I have a mom with hearing impairment. She pleasantly smiles and nods her head. I can tell you if she was in a doctor's office, people would think she totally got it. Didn't get any of it. And as we prescribe so many medicines, right, to try to prevent the side effects, we're good at that now. Is the patient hearing, understanding it, and knowing when to seek attention? And then assistance with taking daily medicines. Do we need to help them figure out that complex regimen that we've just given? Anyone who's prescribed capecitabine and lapatinib, take 1 on an empty stomach, 1 on a full stomach, 2 pills at this time, 3 at the next. It can be a lot, right? So especially if they're scared anyway because they've got a cancer diagnosis. So what happens is you take that, and there's a scoring algorithm, and I'm going to show you a couple of apps you can use so it's way easier. But the bottom line is, here you can score it, 11 questions, and you will get an output. Your patient will be either have low, intermediate, or high risk of grade 3 through 5 toxicity. Average risk is 50%. We've replicated that again and again. 2% risk of treatment-related mortality. Again, 10 sites that participated with this, replicated again. We saw it in both the development cohort and in the validation cohort. I'm going to show you the validation cohort right now. So here's the validation cohort. Pretty good ability to predict. Now, because I am also an oncologist, I said, you know what, and many of the investigators are on this study, what do we have to do all this? Can't we just do the Karnofsky performance status? We're relatively good at figuring out who's at risk. So we had captured this for all of the physicians. These were outstanding physicians. Many top cancer centers across the U.S. participated. They gave us their bet before they started treatment of what the patient's Karnofsky performance status was. What we found was no association between Karnofsky performance status and risk. This doesn't mean these weren't good doctors. They're outstanding doctors. The issue is it's more complicated than one global question of performance status. When we look at the algorithm, there's just a lot of different things that can predict this risk. So where are we going with this? Well, as I said, it wasn't really about developing the assessment. It really wasn't even about predicting the risk. The goal is, how do we intervene? And how do we make this better? We can now identify where someone is on the spectrum, but many patients want and should receive cancer therapy. So before I tell you about that, first I want to tell you is that we need to validate this in other cancer types. So we're doing that in breast cancer. This is an R01 study. We've just finished enrolling 16 sites across the nation, have enrolled patients who are getting adjuvant therapy for breast cancer. We've done the same thing. We've captured everything about that patient, all of the drug dosing. 2 doctors are grading chemotherapy toxicity. Again, Carrie Gross has been tortured for years with this study, on the phone with me every 2 weeks to make sure the data is right. And and I can tell you it is. And then we're looking at biomarkers of aging, which has been really fun, and I'm happy to talk with any of you about that as well. And then lastly, we're now starting to follow these patients as survivors. So this study just completed enrollment this past month of the 700 patients, so we hope we'll be able to show you this data in the next 6 months. And now we have the assessment in several cooperative group studies, so we've really been able to move across the spectrum of the different disease types. We'll be able to give you a disease-specific calculator. I know that's what the oncologists want, so we will get there hopefully within the next few years. But the question is, can we intervene to decrease the risk? So this is how we've done it. Now, you have an incredible situation here, having an amazing geriatrics department, among the top in the nation. So you have geriatricians. Most of the nation does not have geriatricians, is the truth of the matter. I was the only geriatrician at Memorial Sloan Kettering when I started there. I was the only geriatrician at City of Hope when I started there. So it's been something we've had to grow, but we've had to think creatively about how do you touch a whole group of patients when there's so few resources in terms of that training. So this is our study to determine whether we can utilize that assessment and perform interventions that can lead to improvements in patient outcome. And what happens is anyone who's starting a new chemotherapy regimen at City of Hope who's over the age of 65 can enroll. Pre-chemotherapy, they get the geriatric assessment. We calculate their risk. They're randomized then in a 2-to-1 fashion to either usual care or usual care plus the intervention. And the intervention is an NP-driven intervention. We as a multidisciplinary team, I get to hear about every one of these patients, but we have now figured out how do you actually intervene, and I'll show you an example of this. And this has enrolled really quickly. So we're in year 2, 368 patients have gone on this, and the docs love it because there's a group of people who are following their vulnerable older adults. They implement the interventions. You're not needing to do it. And I think it's really honestly just help the doctors decrease the burden for those patients. So tools are available to identify older patients at risk and guide practical interventions. We can now predict what the toxicity is to chemotherapy. We can predict survival. I didn't show you that data, but it's very good. We can uncover problems that you would never find on a routine history and physical exam. It can lead to practical interventions. But the question is, again, how do you do this in daily practice? And that's really the question that I think I get the most commonly is how do we get this done? So I've told you that we developed the assessment. We developed it within the cooperative groups. And we looked to see what's the feasibility of doing this. And we had patients who were starting a cooperative group clinical trial do the assessment. And what we found was that it was feasible. It takes 22 minutes to complete, but that's patient time, not provider time. And the vast majority of patients can do this on their own. We still have someone who's there to help. 1 in 5 will need help in our cancer center, and we've got that resource there, but the vast majority can do this on their own. And most importantly, the patients are fine with this. So when we start asking the questions, people said, are patients going to want to fill out those questions and it's going to be annoying to them? So we had to prove it's acceptable. 92% said the length is just right. They said it's easy to comprehend, not upsetting. In this study, it was a cooperative group study, so patients were very healthy. 87% completed on their own. And then shockingly, 94% of the healthcare providers did their portion, which was those 3 items. So that was pretty good because I know, I'm one of you, so I know what it's like. But then we said, paper pencil is just really not feasible because you have to have a research assistant right there to score it. So we said, well, let's develop this by touchscreen. Is that possible? And we went on this whole journey of developing a touchscreen geriatric assessment. We've now validated it to English, but our catchment area is almost 50% Hispanic. So we needed to do this in Spanish, and then we have it in Mandarin. We're working our way through the different languages. And this is now helping us understand the needs of both patients and their caregivers. So how does this work? Because that's the question I'm asked. So here's one of my patients who was kind enough to let our team photograph her. She checks in. She's waiting in the waiting room and waiting for me and waiting for me. And we say, let's utilize your time. A research assistant comes up to her. She's given the touch screen. Here's an example of some of the questions. Can you go shopping for groceries or clothes? I mean, it's not stuff that's esoteric. It's like, can you do your shopping? Can you do your housework? Can you prepare your own meals? She finishes this. It takes her about 20 minutes. She hands it back to the research assistant. And then what we've done is we've automated it now so that through team science, we sat down with each other, and there was also this Delphi process where we looked at experts across the nation. What did they think we should do based on the results? And we've now been able to figure out that we're pretty consistent in what we recommend. So for example, immediately you can get the results. So the provider gets the results. And now there's a list of potential interventions. You have unintentional weight loss. These are examples. Maybe we should get nutrition involved. The patient's falling. Do we need to have rehabilitation involved? Polypharmacy. They're on more than 5 drugs. They're on a bunch of herbs and vitamins. It's California. Everyone's got herbs and vitamins. Let's get the pharmacist involved. I can't tell you what we found through that part. And then limited social support. They live alone. Do they have a lifeline? If I'm going to give them a dose of chemotherapy, do we need social work involved? And then we give the doctor the chemotherapy toxicity score. So as they walk into the room, they can have all of this information about the patient that they didn't have to do anything really to acquire, and it can help them as they're thinking about what sort of treatment do they want to give. So here is an example. Risk score for this patient, she fell here in the 75% zone, 72% is a risk of score of 10. We've gotten this now into the medical record. And I should say, so I have a young research team. They thought I was completely antiquated when I developed this on the computer screen, and they said they wanted an app. So we have an app now. This is the app. If you want to do this on your device, you can do this on your device. It's very, very quick. Again, 11 questions, and you'll get the tox score. But for me, as a clinician, I'm with all of you. I'm seeing these patients and trying to figure out how do you do all of this. And what I have found is that this really helps when I'm sitting with the patient and making a decision. We go into it together. We might choose to do the same treatment, but we both understand where the risks are. We think about how we can decrease it. We involve the family. Everyone's on board before you start. And most importantly, we get the whole team involved. It's the principles, again, of geriatric medicine is that it's team-based care. The oncologist or geriatric oncologist is one part of it, but it's really a whole team then that starts to get to know your patient along with you and then partners with you throughout that patient's treatment. So take-home message number 5, technology can be utilized to integrate geriatrics and oncology care. This assessment is feasible, definitely in oncology practice or really in any other subspecialty. You can utilize technology to capture the assessment, predict the risk of chemotherapy toxicity, know who is vulnerable, and then intervene to try to decrease that risk. So overall, if I just take you through our take-home messages, number 1, cancer is clearly a disease associated with aging. The number of older adults with cancer is on the rise. There is a workforce shortage. We are in the midst of it. We can change and make the model of care that we think is best for our patients. Education in geriatrics is needed. You and I should set the bar for what that type of education should be. That chronological age doesn't equal functional age. This aging process is very heterogeneous, but there are tools that are available that can help you identify who's at risk, especially for chemotherapy toxicity, that it can lead to practical interventions if you use this tool, and that it's time that we leverage technology to really help us in daily practice so that more of our time can be spent looking at the patient, which is, I know, why we went into medicine. It's that patient interaction, and some of that other information can perhaps be captured for us. So I've presented a body of work, and I love this quote because it really speaks to the fact that if you want to go fast, you go alone, but if you want to go far, you go together. And this is work that was clearly done by a team. I am not a marathon runner, as many of us we've talked about at dinner, but I can climb that mountain with a group of people. And for those of you who are junior in the field, and I got to meet so many of you who were senior, the best part of this field is going on this journey together and getting to know your colleagues and taking that climb up the mountain together. The view is absolutely beautiful, and for us, it is in the Cancer and Aging Research Group. This is a group that we formed when I came to City of Hope in 2006. We now have 25 collaborating institutions, 40 people on the phone routinely every 2 weeks. Carolyn's a great contributor and has presented her work on the calls. 17 of these institutions are actively accruing to our studies. And the whole goal of the group was, we formed it to mentor junior faculty in geriatric oncology and to really mentor anyone who's interested within the field. The only requirement to join, there are no fees. If you want to help an older adult, please join us. That's all. We're grassroots, although we're getting infrastructure. And most importantly, this is my team at City of Hope. They're the ones who are really in the field, and incredible, incredible group. So with that, I'd like to acknowledge our funding sources as well. None of this happens without money, and especially City of Hope that's been very generous to me. And I look forward to taking any questions that you have. Thank you.